Picture this. You are 36 weeks pregnant. Blood pressure has been creeping up. Your first trimester screening flagged you as elevated risk for preeclampsia. The team is watching you closely. Aspirin since 12 weeks. But what if there was something you could actually do at this point to reduce the chance of preeclampsia in the final stretch? Good morning. It is Tuesday, the 29th of July. 5 stories today, plus 2 PBS quick hits. Let us get into it. Story 1. Prevent PE. Preeclampsia prevention by timed birth at term. You know the patient. 34 years old, first pregnancy, body mass index of 31. First trimester screening put her at elevated risk for preeclampsia. She has been taking aspirin since 12 weeks. Now she is at 36 weeks, and the question is there anything else we can do? Enter Prevent PE. Published in The Lancet earlier this year. This is a United Kingdom trial. 8,094 women across 2 maternity hospitals, randomized 1-to-1. At 36 weeks, women in the intervention arm got a preeclampsia risk assessment. If their risk was 1 in 50 or higher, they were offered planned birth at 37, 38, 39, or 40 weeks, depending on how high their risk was. The control group got usual care. The result? Preeclampsia occurred in about 4% of the intervention group, compared to about 5.5% of the usual care group. That is a 30% relative reduction. In plain English, for every 70 women screened and managed this way, 1 case of preeclampsia was prevented. Here is what makes this credible. No increase in emergency cesarean sections. No increase in neonatal unit admissions. Serious adverse events were vanishingly rare, and statistically no different between groups. Why does this work? Preeclampsia at term is driven by placental dysfunction that worsens as pregnancy progresses. The placenta is the engine of the disease. Removing it, by delivering the baby, stops the disease process. So it makes biological sense that delivering before preeclampsia manifests, in women on track to develop it, would prevent it. The screening model uses maternal characteristics, blood pressure, uterine artery Doppler, and placental growth factor. This is the first randomized trial to show that late pregnancy risk stratification combined with timed delivery can actually prevent preeclampsia at term. The Fetal Medicine Foundation 36-week model is already used in some Australian centres. This trial gives it legs. Tell your wife about this one. The limitation. It is 2 United Kingdom hospitals, and the trial was open label. Women knew which arm they were in. But the outcome was objective, preeclampsia diagnosed by international criteria. This is solid. Story 2. Rapid microbiological point-of-care testing in primary care. It is Monday morning. Your first patient is 45, with a sore throat, cough, and fever for 3 days. You are thinking viral. But you are not certain. You reach for the antibiotic script pad, or do you? There has been huge hope that rapid point-of-care testing could crack the antibiotic stewardship problem in primary care. The logic is seductive. Swab the patient, run a multiplex PCR in 45 minutes, identify the pathogen, and prescribe, or do not, with confidence. JAMA Internal Medicine, published just this month. 552 patients across 16 general practice sites in southwest England. Randomized to get the rapid microbiological test, which detects 19 viruses and 4 atypical bacteria, or usual care. The question was straightforward: does having the test result change whether you prescribe antibiotics that same day? It did not. 45% of patients got same-day antibiotics in both groups. Identical. 0 effect on the primary outcome. But here is where it gets interesting. In the subgroup where a virus was detected, antibiotic prescribing dropped dramatically. About 2/3 fewer prescriptions. And in patients with chronic lung disease, the test also reduced prescribing. But these were subgroups, not the primary endpoint. This is a sobering result. It tells us that simply having a pathogen result does not change prescribing behavior in the moment. Why? Because a positive virus test does not rule out bacterial co-infection. Because clinicians prescribe for patient expectation, not just lab results. And because the test takes 45 minutes. In a 15-minute consultation, that is a problem. The contrast matters. C-reactive protein point-of-care testing measures the host inflammatory response rather than the pathogen. It has multiple trials showing it safely reduces antibiotic prescribing for lower respiratory infections. The difference is that C-reactive protein gives you a global signal of bacterial infection, which is what you actually want to know. The microbiological test gives you a pathogen name, but detection is not the same as pathogenicity. Commensals colonize the nose and throat. The bottom line. Rapid microbiological point-of-care testing in primary care is not the stewardship silver bullet we hoped for. C-reactive protein testing still has better evidence. Save your money. Story 3. NORD ICC at 13 years. Colonoscopy screening, reassessed. Your patient is 58. He is asking about bowel cancer screening. He has heard colonoscopy is the gold standard. 90% effective. Prevents cancer. Saves lives. You have been telling patients this for years. But what does the randomized evidence actually show? NORD ICC. The only randomized trial of colonoscopy screening versus no Published in The Lancet, 13-year follow-up. 84,583 people, aged 55 to 64, in Norway, Poland, and Sweden. Randomized 1:2. Invitation to a single screening colonoscopy, or no invitation. The cancer incidence result. Reduced by about 19% in the invited group. 1.46% developed colorectal cancer versus 1.8%. So roughly one cancer prevented for every 280 people invited. But here is the headline that will surprise you. No significant reduction in colorectal cancer mortality at 13 years. The numbers were 0.41% versus 0.47%. The confidence interval crossed 1. How can you prevent cancer, but not prevent cancer death? 2 reasons. First, only 42% of people who were invited actually showed up for the colonoscopy. That dilutes the effect enormously. When the researchers looked at people who actually had the procedure, cancer incidence was cut nearly in half, and mortality dropped by about 30%. Second, colorectal cancer mortality in the control group was much lower than expected when they designed the trial. Probably because of better awareness, incidental detection, and access to care. When your baseline risk is lower than planned, it is hard to show a mortality difference. A Lancet editorial was blunt. Colonoscopy screening has been promoted as cutting cancer incidence and death by at least 50%. This trial says, not so fast. At the population level, the benefit is more modest than the modelling studies promised. For Australian general practice, this matters. Our National Bowel Cancer Screening Program uses the fecal immunochemical test every 2 years from age 50 to 74. Participation sits around 40%. This NORD-ICC trial does not change the program, but it does mean we need to be honest with patients. Colonoscopy reduces cancer incidence. It probably reduces mortality if you actually do it. But population-level uptake is the Achilles heel. The fecal immunochemical test remains the evidence-based backbone of screening. When patients ask for colonoscopy instead of doing the FIT, frame it honestly. FIT is simple, done at home, and has program-level evidence. Colonoscopy is more invasive, requires bowel prep, carries small but real risks, and its population-level mortality benefit is humbler than the marketing suggests. Story 4. PPI deprescribing. The patient letter that works. You know her. 68, on omeprazole for the last, how long? She cannot even remember. Started after a course of non-steroidals for her knee. Never stopped. She does not need it anymore. But how do you get her off it? JAMA Internal Medicine, published in June. 34,409 patients, 683 general practice clinics in France. Everyone had been on a proton pump inhibitor for at least a year. Cluster randomized to 3 groups. Usual care. A general practitioner-facing letter with a deprescribing algorithm. Or a combined patient and GP intervention, where patients got a brochure directly in the mail explaining deprescribing, and the GP got the algorithm. The result? The patient-facing intervention worked. 15% of patients in the combined group reduced their proton pump inhibitor dose by at least half, compared to 7% in usual care. The GP-only letter. Barely better than usual care. About 8%. The key insight. The effect came from the patient brochure. When patients understood why they should stop, they stopped, or they asked you to help them stop. General practitioners getting a letter alone did not move the needle. We all have patients on long-term proton pump inhibitors who do not need them. This trial shows that a simple patient education intervention, a letter, a brochure, can nearly double the rate of successful deprescribing without worsening reflux symptoms. Their reflux scores did not change. This is deprescribing evidence you can act on tomorrow. Story 5. Majesty. Obinutuzumab for membranous nephropathy. 52-year-old man. Nephrotic range proteinuria. Biopsy confirms primary membranous nephropathy. Anti-PLA2 receptor antibodies positive. You are referring to nephrology, but what will they do with him? Majesty. New England Journal of Medicine, June this year. Phase 3. 142 patients with primary membranous nephropathy. Randomized to obinutuzumab, a type 2 anti-CD20 antibody given intravenously, or oral tacrolimus. The result? At 2 years, complete remission, meaning proteinuria normalized and kidney function stable, was achieved in 37% of the obinutuzumab group versus just 6% of the tacrolimus group. That is a dramatic difference. About 1 in 3 versus 1 in 17. Membranous nephropathy is an autoimmune kidney disease causing nephrotic range proteinuria that can progress to kidney failure. Current options, tacrolimus, cyclophosphamide, rituximab, all have issues with efficacy or toxicity. Obinutuzumab is not TGA approved for this indication yet, but this trial will change the landscape. If you are referring a patient with membranous nephropathy, know that the treatment paradigm is shifting from calcineurin inhibitors to anti-CD20 therapy. Quick hits. 2 PBS changes to note. First, lamotrigine is now PBS listed for bipolar disorder, effective from May this year. This is a big deal. Lamotrigine has been first line for bipolar depression in the electronic therapeutic guidelines for years, but patients were paying full private price. Now it is $25 a script, or $7.70 with a concession. 3 brands only, Lamictal, Lamotrigine GH, and Sandoz Lamotrigine. If you have patients with bipolar disorder paying out of pocket, this changes things. Second, nitasinone, brand name Orfadin, will be PBS listed from August 1st for hereditary tyrosinemia type 1. This is a rare metabolic condition. You probably will not see it in rural practice. But it is moving from the life-saving drugs program to the PBS, which means better access for the small number of patients who need it. Recap. 5 stories today. Prevent PE, screen at 36 weeks, offer planned birth for high-risk women, prevent 30% of term preeclampsia. Rapid microbiological point-of-care testing does not reduce antibiotic prescribing in primary care. NORD ICC at 13 years, colonoscopy cuts cancer incidence, but not mortality at the population level. Proton pump inhibitor deprescribing, patient-facing education doubles successful dose reduction. And Majesty, obinutuzumab dramatically outperforms tacrolimus for membranous nephropathy remission. See you tomorrow. Stay sharp.